I am sitting here, not in the same room. I am in Austin, Texas. I believe Dr. Joseph Pinzone is in California, if that's correct. Welcome to the
That's
show.
correct. Thank you very much for having me on.
Yeah, what a treat. I'm going to do this. Pretend I'm walking down the street. We bump into each other and we start introducing. I'm like, Freddie, I do podcasting. I'm an advocate for wellness and healing technologies. Dr. Pinzone, what do you do?
So one of the things I do, among many, is I help patients who are living with cancer to improve the traditional treatments that they might be given. And I do that through employing a modality called hyperthermia.
Beautiful. And if you had to explain again to the layman, what is hyperthermia?
Mm-hmm. Well, it's interesting because in this country, you do have to specify the type of hyperthermia. And what I mean by that is we have an FDA approved device that delivers local regional hyperthermia, meaning that we target particular tumors. So it's local therapy. It doesn't treat the whole body. It's not whole body hyperthermia. I'm not aware of that actually existing in the same way that I would treat somebody, and I'll explain that as we go. And basically what we do is we use ultrasound, and it has the same physics as diagnostic ultrasound. So the reason you probably have never heard of somebody having an ultrasound of the lung is as soon as you hit air, an ultrasound wave will stop. Similarly, you can't really get an ultrasound of the brain because bone would have that bounce off. In our case, bone is a heat sink. We don't go through air, but we could treat every other part of the body with hyperthermia. And so that's breast cancer, prostate cancer, colon cancer, head and neck cancer. The list goes on and on and on and on. So our device is FDA approved to treat all solid tumors in combination with chemotherapy or radiation therapy. And the mechanism is fascinating. So we're not burning anything. We are leveraging the ability to change physiology with fever, or in this case, slightly over the fever threshold of heat. So just to give you an idea, when we apply our device over a particular body part that has a tumor below the skin or on the skin for that matter, we aim to heat that tumor to 106 to 109 degrees, okay, and 41 to 43 Celsius. And when we do that, something very interesting happens. It increases the blood flow. Now, why would that be important? Because cancer is very dichotomous. So if you were to take any given cancer cell, it might actually be pretty fragile, but cancer is like evolution in a bottle infused with lightning. Those cells just mutate, right? So if I took a small little tumor and I did 100 biopsies and I did a genomic analysis, what genes are, expressed, and some of which may, of course, be different than normal cells, that's what make cancer cells. They would actually be different in the 100 biopsies, overlapping, granted, but a little bit different. And so the point is, cancer has so many different facets to it that it's not a normal, it's not like creating an organ. So what happens is when cancer creates blood vessels, as it has to, it doesn't do it really well. And so the walls of the blood vessels are very, very porous. They don't have a good integrity. And so they collapse, particularly at the center of the tumor. Now, on imaging, sometimes you get central necrosis, meaning the center of the tumor dies, but often enough, you get a mutational pressure that allows those cancer cells to live at a low oxygen environment. So now you've got a haven where some of the stem cells can live. They can't really get penetrated well by chemotherapy, and radiation uses oxygen to damage DNA. That's a major way radiation works. Yes, it definitely, the energy of the radiation does some cell killing while the patient's on the radiation table, but so much of it occurs after the radiation. So here's how we work. I'm going to do it as a 1A, 1B, and then a 2 and a 3 in terms of mechanism. So 1A and 1B are based on the same physical principle, which is we increase blood flow. And a lot of people think, oh, that can't be good. Well, those cells, remember, they don't really like oxygen anymore, A. B, it's very hard to get the chemo penetrated into that portion of the tumor that is the center of the tumor. So when we do that, while somebody's getting chemotherapy, we get more of the chemotherapy to enter the center of the tumor. That's a good thing. So that's 1A. 1B, same principle. Increase the blood flow while someone's getting radiation. I'm just doing A and B because it's chemo versus radiation. So we radiosensitize. Translation of that is we make radiation work better. So once the radiation, and many types of chemo as well, but radiation for sure, a major way that it works, as I mentioned, is it takes oxygen, it creates oxygen-free radicals on DNA, and now you've got damaged DNA. Granted, people will often ask, doesn't radiation, doesn't chemo do that to normal cells? In some cases it does. It preferentially does it to cells that are already a bit broken, that are already dividing very quickly, right? So now that you've got the damaged DNA, whether it's from radiation or whether it's from chemotherapy, you're in a race to be able to get those cells to try to divide. Because if they divide while the DNA is broken, okay, then they're going to go into apoptosis, which is programmed cell death. But every cell in our body has the ability to repair DNA. If it didn't, we'd all get cancer in the first week of life. So even cancer cells can repair DNA. So mechanism number 2 is heat slows the enzymatic repair of the DNA, okay? And then mechanism number 3 is a bit of a head fake. So here's where you've got a fully accepted Western, I say fully accepted, not everybody accepts it, but it's FDA approved. It's typically paid for by insurance. People don't just not aware. Okay, that's why we're doing this. And we don't even really understand a lot of that it exists, how it works. So that's what we're going through now. So you can consider that a biohack, and I know people like that word, and it's fine with me. It's no problem, because this next one, the third one, is really a head fake. So basically, what we're doing is we're heating a tumor, and we're giving it the equivalent of a fever. So now you've got heat shock proteins. Their name tells it all, right? So they will be secreted in the case of a fever or in the case of external heat. That now, we're not talking heat on the skin. If you have a melanoma, sure, that counts heating the skin, but your skin's a really good insulator. So for us to get down 10 centimeters, we go right through fat, so it doesn't even include the fat, but 10 centimeters, which is almost 4 inches, right, between 3 and 4 inches. We are getting very deep into the body, much deeper than you can by just sitting in a bath or anything like that. And when you give that part of the body a fever and you get the heat shock proteins that are secreted, then all of a sudden it stimulates the immune system. And the immune system has to be very specific in certain kinds of infections and in the case of cancer. So now you've got dendritic cells, part of the immune system, among other antigen presenting cells, taking these mutated proteins and showing them. This is an active process. It happens in infection too, right? Showing them to T cells. So now the T cells can go back and attack the tumor. Now, all of what I just said sounds good on paper, but like everything else, there's no guarantees. I have seen this work incredibly well. We have hundreds upon hundreds of studies that have demonstrated the efficacy, and I can quote you some of the data as we go along in our talk. But I wanted to make sure we got the full, answer to your question about what is the mechanism. Pretty well worked out. We got those 3 mechanisms, and they're really cool. And when they work, man, we hit it out of the park.
That's incredible. I had no idea that it was a spot treatment in my understanding. From my experience of hyperthermia, we hear about, especially Switzerland has a few centers. I've had friends do whole body hyperthermia for autoimmunity and severe Lyme disease, in which the infection had crossed the blood-brain barrier, neurological
Mhm.
symptoms, and it was man, when they would tell me the story of them trying to withstand this therapy and cool packs in different areas so they could remain cognizant and just suffer through it, I was like, wow, this is a feat. This sounds much better and much more accessible.
Well, it's very interesting that you should say. So here's the thing. Um, there, to my understanding, the only FDA-approved hyperthermia in this country is local regional hyperthermia,
Hmm.
and we have one of the devices that is FDA-approved. The deal with whole body hyperthermia is it's a fascinating concept. So let me go through it. In this day and age, there's no place that I'm aware of that does that in this country. And I say it that way because I have also heard various stories of people having their body temperature raised, right? So it depends what you think the sweet spot is. And, it's been fairly well defined in cancer, that 106 to 109. So you really can't survive very long if that were the case, right?
Yeah.
Doesn't mean you can't get to fever temperatures as as dangerous as that might be. But if we do harken back to William B. Coley, okay, he was a surgeon in New York in the late 1800s and the early part of the 20th century. Um, they still have the William B. Coley Award in because he created the first cancer vaccine. So let me tell you about whole body hyperthermia. It's not done anymore, okay? But
Hmm.
he noticed a young girl with sarcoma, a type of cancer, not a common type, but a type of which there are many subtypes. And she contracted a strep infection called erysipelas. And correlation does not always mean causation, but he noticed that her cancer regressed, not just the one area, but multiple areas. And there are documentations back in the time of um, patients getting very, very, very serious infections when they were before antibiotics, the 17th, 18th century, smallpox, for example. You might be febrile to 105 for 3 weeks. And if you were lucky enough to survive, what was noted back then is a very small percentage of people who
Hmm.
had tumors that, no scans, so let's call it breast cancer or something that you could palpate. Very small percentage had regression, total or partial,
Hmm.
temporary or permanent, but it was there and it was undeniable. Now,
Yeah.
nobody knew what to do with it. Coley took it and then started injecting streptococcus into the tumor. Now, he quickly realized probably better not to give someone erysipelas because they don't always do so well. So he killed the streptococcus, combined it with a bacterium known today as Neisseria, called something else back then, gram positive, gram negative, put them together, those heat killed strains, and that was the first cancer vaccine. And
Wow.
and when he passed in 19, I think it was 36, it sort of just never got revived. But he got probably a 50% durable, I mean 10-year response rate where the tumor that he injected, as well as the metastases, that's called an abscopal effect, Latin for away from the scope, right? They regressed. It was absolutely astounding. And in those situations, it was probably a combination of the immune reaction against the bug and
Hmm.
the durable fever that people got. So
Yeah.
now what we do is we leverage the fever part of it and we leverage it in a local way.
Yeah, it's so fascinating, and every time I have these conversations, I'm reminded of the systems within the body that allow for the body to fight cancer, which already exist, which we're seeing that these treatments aren't necessarily, well, we could theorize or build a working theory. Are they doing the work? Are they doing the magic? Or is it the body's fever that's really activating a terrain in which the body can have a better battle against this tumor, the cancer? Are you aware of the I think it's G207. It's an oncolytic virus, which means it's an engineered virus to target cancer cells, ignoring healthy cells. So this is something, I think it's a derivative of the herpes virus, in which it's been used in certain brain cancers, correct?
You know, I have a vague notion of what you're talking about, but I don't know a lot about it. So just in full disclosure to everybody here, I'm an internal medicine doctor, and I have a subspecialty in endocrinology. Now, I'm the primary doctor for endocrine tumors, much like a urologist might be for prostate cancer, until,
Mm-hmm.
let's say, those things, God forbid, get metastasized. Then patients do end up going to oncologists. But I ran an NIH-funded lab in breast cancer, so I know a lot about tumor biology. But I don't know the ins and outs of oncology like an oncologist would, and I don't practice oncology by
Yeah.
any means. Yeah.
Great. Great
But
disclaimer.
that's yeah. But that's an important. But what you're quoting is we have so many things on the horizon that are allowing us to really understand how do we leverage the body's own systems to be able to attack the cancer. That's what the new immunotherapies are about, right?
Mm-hmm.
And they don't work on typically. I'm not an expert, not an oncologist. Remind people of what I just said, but my understanding is they don't really work on a large percentage of people in many cancers. But when they work, where they really work, you have to be susceptible. But let me answer your question about can we leverage the body's own system, right?
Mm-hmm.
Now, we all know the story through various people of notoriety that testicular cancer is pretty darn curable. 100%, nothing's 100%, but it's pretty curable.
Yeah.
Well, the testes live a few degrees below what the body temperature is, right? That's why the scrotum is there. So it's almost an auto hyperthermia when those tumors invade the inside of the body, because now they're living at 97.6 degrees, okay?
Mm-hmm.
And so they're living at or excuse me, 98.6 degrees, 37 degrees Celsius, right? And average temperature. And so that's higher than testicular cells normally live at in the scrotum, right? That's the whole idea of keeping them
Mm.
away from the body. So now they're exquisitely sensitive to chemotherapy, and they're living in an environment that's higher in temperature than they would normally live in. So it's, again, very difficult to look at correlation and causation, but reasonable evidence to say, that's really interesting. There may be something to that differential of temperature that makes those testicular cancer cells more sensitive to chemo because they live in a higher temperature environment. We don't know for sure.
Yeah. Yeah. So, having gone through testicular cancer and etoposide cisplatin treatment
Yeah,
myself
yeah,
with a retroperitoneal lymph node dissection, it is fascinating. It's also fascinating because before they had that combo of chemo, it was a terrible diagnosis, early 70s, because it's such a rapidly progressing cancer. Does that happen, to your point, because all of a sudden we're in this perfect petri dish, that's a
yeah.
better temperature than where the testicle cell normally existed? Really fascinating.
Right. And so just the same as our modality, hyperthermia, is meant to improve the efficacy, the effectiveness of chemotherapy, of radiation therapy. We don't use in general, we don't use hyperthermia alone. Um, but boy, it does often, I have to use that word because there's no 100%. Nobody should be making any promises in medicine. That's not a
Never.
good sign. No,
Yeah, we
no.
don't do that here.
No, no. No, and your doctor shouldn't do it either, and you shouldn't walk away with that even. So, but again, we really facilitate the entry of the chemo. We facilitate the damage of the DNA that's meant to happen with the with the I'm so sorry.
No, it's okay.
Yeah, with the radiation.
Yeah. Yeah. No, it's fine. It's looking, I got like 100 different ways for people to get a hold of me here. I put everything on, I put everything on Do Not Disturb.
Yeah,
And but I love it. Technology always gets its way in.
I
I,
know.
I want to, I want to look at, this idea of, this localized treatment in the body. Can you give me a scope of what that would look like? Are there limitations? I know we've said, Maybe we didn't say this, but from my understanding, this is a solid tumor therapy. This does not work on a blood cancer, a leukemia. Is that
Correct.
true?
Yes. Leukemia or lymphoma, there's a reason for that. So those cancers are by definition systemic. Now, someone might argue, look, stage 4 cancer, that's systemic as well, your local therapy. But you have a target, you have a collection of cells. You kind of have that in lymphoma too, but it just never worked out that we're FDA approved just in solid tumors. You're absolutely right. And
Okay.
it gives us a good solid target to aim at. And it also, look, if you've got early stage cancer, let's do everything we can. You got one shot to get rid of it. If it comes back, I'm not saying that you can't get rid of it, but it's typically much harder because cancer continues to mutate with time, right? So really, if you got curable cancer, the idea is to try to cure it the first shot. Of course. I mean, it goes without saying, but it is really critically important. If you have stage 4 cancer, take the other extreme, we can still be very useful to you because, for example, people get, many, many, many liver metastases. Well, you can't live without a liver. So, again, we're part of the solution. Cancer right now, we're still, except for some very specific targeted therapies like you were alluding to with oncolytic viruses, with targeted therapy that target specific molecular pathways, right? I think 50 years from now, medical students are going to look at their attending doctors and say, did we really do surgery for cancer? Right? Because what's going to happen, the bioequivalent of Moore's law, my understanding is, you could argue this either way, but it seems to be accelerating faster. So once we start to be able to genotype on a regular basis and we understand what mutations are actionable and we have more tools because we're now being able to create through technology, AI funded or AI based technologies, we're able to improve our ability to create targeted molecules that will target that aberrant pathway. We can then start to stack therapies. We can have some AI algorithm say you could use this, then you're going to anticipate this mutation, this, you're done. We don't have that right now for most cancers.
Yeah.
And for, we have standard of care, which is, where we're at. It works, but it's on a continuum, right? It works better in some people and not as well in others.
Yeah. As you said at the beginning of the podcast, we put 100 people in the room with the same type of cancer and we look at that tumor and the variables, the bioindividuality of the cancer is very, very different. So again, I like this idea of, I'm very drawn to the idea of supporting the body systems and supporting the terrain. Are there limitations with this treatment in a solid tumor, as in the number of metastases, like how much time can you spend on a body? And maybe even another follow-up question would be, what would it look like for someone to incorporate this treatment into their cancer journey?
Yeah, so I look at it as thinking about how best when the patient and I together create a treatment plan. My approach is very straightforward, and that is I'm the recommender, they are the boss. Having said that, as much as I want and need them to be comfortable, I also have to be comfortable. So I have the luxury of having a good amount of time to spend with people. We have a good back and forth. Hyperthermia has a very favorable adverse effect profile. We're heating to just above fever temperatures. We don't heat enough to get a 3rd-degree burn. Have I seen blisters? Yes, they occur very unusually. Do sometimes people get some bone pain if we're over a bone? Sure. Do they have some warmth afterwards? Yes. Do we get one-off things that happen? Sure. But basically, it's a gentle therapy among the types of therapies that people are getting. And so we're not so much limited in that. What we're limited in is a few things. Number one, does insurance pay for it? Usually, yes. If not, it's not an inexpensive therapy. So that's one thing to think about. Number two, pretty time intensive. So some of the early studies vary in terms of how they were done, because early on, this modality was given over to radiation oncology departments, and that's not a bad thing. But early on, the radiation oncologists needed to understand it. So the way they understand things with a physics mindset is they would often put probes inside the body. We don't do that anymore. We measure skin temperature, and we have different algorithms to know reasonably well how much we're heating at depth. So it's a little bit different. But the point is, a lot of the studies were done twice a week. Some of the studies were done, every time you get radiation, you get hyperthermia. So we really create a treatment plan. And what I find is that the more people do hyperthermia, the better the outcome typically. And again, that's going to be a little bit variable in terms of how the studies were done. So we're very time intensive, and it takes about an hour to do one, to do a treatment. And so we really want to be able to treat you as a patient through your radiation therapy, potentially somewhat beyond. And I'm very upfront with people, because there's no specific data that says you should treat beyond. But remember, that DNA, if it is not dividing and it gets repaired, you've got a problem, because it's not going to go into apoptosis. So, and then so radiation therapy usually is, maybe a month. Sometimes it's only 5 days. Chemotherapy can last for months. So, if somebody lives around the corner and they have free time, or they make free time and their insurance covers it, okay, those limitations, we can certainly overcome them. And I always talk to patients as though they live around the corner, fully acknowledging I don't waste people's time, I don't waste people's money, I give them all the data. We create the plan that's practical for them. And so the reason that I'm going through all this ad nauseum is because it brings up the idea of, can we treat different metastases? So I would say we are beholden to the underlying therapy. If that's working, we have a good chance of making it work better. Okay. If it's not working, we're probably not going to be able to, in and of ourselves, in and of our own therapy, help the patient. And the reason I bring that up is because roughly, and we've not studied this, we don't do studies, we're a clinic, okay? We're not involved in studies at the moment. There are other places that are. There are many places that were early on in the 80s and 90s and early 2000s, and they continue on, by the way. But I have personally seen various people in whom we have pretty substantial evidence that we're helping them, and we're hit a home run. So I'll give you 2 examples, okay? Three examples. So number one, we had a woman with breast cancer, and she got neoadjuvant, meaning before surgery, chemotherapy. And she had the breast cancer, and there was possibly some lymph node involvement, and it was a left-sided breast cancer, left-sided lymph nodes. So we just treated the breast because we weren't sure if the left-sided lymph nodes were involved. The breast tumor went away with chemo. Again, the bulk of the credit goes to the underlying therapy. We're there to help, okay? But her lymph nodes popped up. We then switched to hyperthermia after probably a month and a half to the lymph nodes, and those disappeared. That's pretty good evidence that we help that patient. That's not a typical result. Example number 2, we had a gentleman with stage 3 rectal cancer. And so insurance typically will pay for 1 treatment per day. Well, this gentleman decided that it was in his best interest to pay for 2 treatments per day, and he did it throughout the 4 months of neoadjuvant chemotherapy. And the reason he did 2 treatments is because he had a lymph node that was right in the middle of his body, right below his belly button, between his belly button and his back. And because we treated the rectum, that was the main area that he had the tumor. That was the only other visible part that he had. Now, he had 10,000 cells in a lymph node somewhere, and the chemo was doing the systemic work. Again, bulk of the credit goes to the chemo. But nonetheless, he got to the point where he avoided a life-changing operation. I mean, he had the operation, mind you, but he avoided a life-changing operation of the tumor was so small, they didn't have to sacrifice much of the rectum, so he remained continent, which was really, really important to him. So that's another example. And the last example is we had a lady with HER2 positive breast cancer. So she had tried Herceptin, then Herceptin plus Perjeta, then Kadcyla, all HER2 aimed therapies. They worked and then they didn't work. She was referred from a radiation oncologist because she had an open chest wound, a chest wall recurrence. That's where we have really good data in breast cancer. Now, she also had a liver lesion. She also had a bone lesion. So we treated for about 3 months with the okay of her radiation oncologist. She came to me and said, Dr. Pinzone, I really want to try this last HER2 therapy called Enhertu. So I said, look, we got to talk to the radiation oncologist. We talked to the radiation oncologist. She said, sure, go for it. We tried it. Chest wall came to normal skin, normal skin. When just before it was normal skin, we realized that the liver lesion was shrinking. So again, we're not claiming magic. We're just, so we switched to liver, got rid of that. Nothing seemed to be touching the bone. So we, after about a month and a half, went to the bone. Again, this lady really did live, not right around the corner, but live in commuting distance, right? So after about a year of treatment, I know this sounds quite something, she went from stage 4 disease to no evidence of disease. Okay. She then came less frequently, stayed on the Enhertu, and then she outlived the Enhertu studies. So they didn't know what to do with the Enhertu. They gave it less frequently. They wanted her to stay on it ad nauseum. At some point, she cut it off. She said, look, I got to just be me. If it comes back, it comes back. To this day, we've not heard back from her. And this was a couple of years ago. So, again, sure, could it? You can't separate two therapies. Could it have all been the Enhertu? It's possible. She had tried 3 other regimens that target HER2 before. So again, I think, and again, that's not typical results, but it's so cool.
Yeah.
So,
Well, I'm reminded of the extremely small, if non-existent, adverse reaction list.
Yeah.
So if it's something that we can possibly get some coverage for,
Yeah.
again, if the time is, if the person can manage being at the center physically, I don't understand why people wouldn't do that. How do you plan to open other centers in the United States? Because right now there's just one, correct?
There's 2 actually.
There's 2.
Yes, I'm sitting in my fairly newly opened within the last 6 months. Center in Irvine, California. We have our initial one in Santa Monica, and we have a second one in Irvine. Our plan is to open more centers, and there are a number of reasons why this particular therapy didn't take off, and there are a number of reasons why we definitely get referrals from some oncologists and from some radiation oncologists. But the vast majority of patients we get are patients advocating for themselves.
Mm-hmm.
And it's really interesting because what has happened since 1987, so we've been FDA approved. This technology that we use, our device, has been FDA approved since 1987. And it's been known, so it's not like it's foreign, okay? But it really, because it was in the radiation oncology space, it just never really took off. And then you had a bunch of guidelines that got put in place. So now you're in a situation where typically the quarterback of a person's cancer care is their oncologist. And if they don't know about us, and if we're not incorporated in the guidelines, even though, look, doctors are great people. Nobody I don't mean to say that they're practicing cookbook medicine, but they're following guidelines, which is an appropriate thing to do. Certainly, they're thinking outside the box. They're now looking for mutations, but it doesn't happen universally. And I can understand the psychology. It's hard if they don't know about a therapy, even if we're FDA approved. If we're not in the guidelines, how does that affect the therapy? So it's tough a lot of times for doctors to wrap their minds around it. But I have conversations with my colleagues all the time. And, many of them, and I get varied responses, but we're here, we're typically covered. We don't make any promises, but we do have some really good results, and sometimes we don't have good results. Just like when you go to the oncologist, is that really any different? But as you say, so I think you framed it perfectly. That's exactly what I say to the patient. I say, look, if it's covered, if you can swing it, we give you an edge. And whether it be the stage 4 cancer where we're going to, I never say people can't be cured. That's not for me to say. We have to be realistic. Stage 4 cancer, that's a heavy lift, okay? But if you're aiming for cure, again, I kind of go with the one-shot theory. Best to
Yeah.
get it on the first shot. So anyway, no real reason not to try this. Agreed.
Yeah. I have a question for you. How is this, if it's FDA approved, can we talk about data first? You
Sure.
mentioned
Yeah.
efficacy, and how would people
Right.
frame that? Because a lot of times when you'll go in and let's just use, maybe it's testicular cancer, like, Freddie, based on cell makeup and the genome and yada yada yada, your odds look like this. It's like what are, and because we're going to use etoposide and cisplatin, or because we're going to use this type of radiation, what are the data / stats look like on hyperthermia?
Sure. So when a therapy or a therapeutic modality is first investigated, typically it's investigated in patients who have advanced disease. One of the reasons why is because patients with early disease typically have a much longer lifespan, and typically don't, they're often cured. And so it's just not practical to be able to do a study in earlier stage patients. So most of the data comes from later stage patients. And again, respect the fact that when I talk about the data, I'm talking about the tumor that was treated. Unlike William Coley, who got that abscopal effect, we can't really claim to do that. I wish, and the immune reaction would tell you that maybe we can, but that's not what we see. Having said that, what the data tells us is that, as an example, most of the outcomes are the percent of complete response. Okay. So, for example, if we looked at breast cancer, you get an increase in complete response by 44%. Okay. So in one study, and again, most studies, by the way, show efficacy of hyperthermia when it's compared with radiation alone or chemotherapy alone, right? So when you combine it with hyperthermia, most studies show some benefit. So as an example, one study that we quote, increased the complete response rate of typically chest wall tumors from 41%, getting rid of it altogether, to 59%. So that's an increase of 44%. Now, if you have, and so head and neck cancer, it increases it from 41% to 83%. Okay, that's a 100% increase. But percentages are a little deceiving. You have to apply them to the underlying likelihood that you're going to get rid of that cancer, right? Cervical cancer, increased complete response rate by 28%. Rectal cancer, interestingly, increased 5-year survival. Again, one study. They're somewhat cherry picked. Okay, these are representative of most of the studies. Some don't show a response. None of them show significant harm that I'm aware of. But increased 5-year survival by 46%. Now, and again, these are all with radiation. One of the reasons why we quote the radiation data is because it's pretty standardized how those are done. Chemotherapy, there are generally similar results percentage-wise. The studies are a little bit earlier, not always phase 3 trials. Some of them are. But we're FDA approved to be used with chemo. We do that. The machine does the same thing. It opens up the blood vessels the same way whether you're getting chemo or radiation. So those are some of the data that we quote and say, it's all well and good, but it doesn't go from 41% to 100%. It goes from 41% to 59%. So if you then Now, if I only treated people that met the criteria for a study, patients walk through the door, they're not going to all be study patients, right? They just have
Hmm.
cancer. So you have to apply it in a judicious way. So we've had patients where they've had too numerous to count liver lesions. Well, that's not going to be a 41% chance of getting rid of all those tumors. It might be a 10%. Okay. Again, maybe I'm just making that up. Maybe it's less, maybe it's slightly more, what have you. It's not great. But if we increase that by 50%, that goes to 15%. I've seen it happen, and I've also seen it not happen. So, I think the real thing is to have an honest conversation with people. We've had most of our patients say, look, I'm going to take any edge I can get. And
Mm.
again, if they have the coverage, they have the time. With stats like that, even if it's one of the tumors, and you don't know till you try, right? And so if you have 3 different tumors, like the lady with HER2 positive breast cancer that I showed you, we're looking at one at a time. So if
Hmm.
we're getting major effects on one and not on the others, again, sadly, that's almost an internal experiment. We're probably helping because that tumor shrunk, the other ones maybe didn't. So then we switch to another tumor, fully recognizing that patients could end up getting a new tumor. So again,
Yeah.
we understand the terrain. It's fraught with issues, but those issues are openly discussed in my office. And we're always dealing with risk benefit and feasibility.
Hmm. I'm assuming because this is such a specialized therapy, and they're already most times under the guide of a oncologist, that you're not having a conversation about lifestyle adjustments, food, hydration, nutrition, sleep hygiene.
Correct. Those are not things that I have primary knowledge about in the sphere of cancer. And so I
Hmm.
stick to what I know. I
Great.
understand tumor biology. I understand the application of uh, low levels of heat vis-a-vis hyperthermia, and that's what I stick to. And
Yeah.
any questions that patients have, and they ask me all the time questions about their underlying therapy. And the first thing I say is, remember, I'm not an oncologist, so here's the way you might want to phrase the question. So one of the twofers that patients get by coming to our clinic is um, everything cuts both ways, right? So there's some advantage to me not being an oncologist in the sense that I am an educated physician who has a special interest and knowledge in tumor biology, but I don't apply things. I don't have treatments to apply. So I have a little bit of a arm's length view of those treatments, which helps me to help the patients formulate questions for their oncologist. And
Hmm.
that's a lot of the value that we add beyond the hyperthermia.
Yeah. Yeah. Beautiful. That makes a lot of sense to me. I also, my other question about the this integration or adding this therapy into a paradigm, how is this met within the standard medical model, especially within the United States? We get a varying degree of people, wanting to say, well, I want to do this and this and this. And, again, the internet, it's like, it's rife with all these therapies that may or
Yeah,
may not be beneficial.
right.
Um, how do you have that conversation with a doctor or an oncologist in which
Yeah,
you try to show them there is validity here?
yeah. So it's very interesting because the vast majority of patients come into us and we advocate full disclosure. We also let the patients know that in our experience, they can expect one of 3 responses. Either the oncologist or radiation oncologist, because radiation oncologists often are involved in the patients that we're treating, um, will know about hyperthermia and embrace it. So that is not particularly common because hyperthermia is, although it was part of the radiation oncology textbook up until one of the main ones up until the last edition, they kind of cut it out. And so not a lot of radiation oncologists and so there's not a lot of centers in the US, right? So not a lot of them have exposure. So it's unusual to get an embrace of this, but it's not unheard of. I mean, many oncologists and many radiation oncologists do embrace hyperthermia, but it's not the most common response. Another bucket of responses would be, well, you know, you do what you think is right. If it's not hurting the therapy I'm doing now, you know, that's great. Have at it. And I can live with both of those responses. I can live with anything. I mean, people can say what they want, but
Mm.
I've had a third bucket where oncologists, and this is not typical either, by the way, but I've had oncologists and radiation oncologists say to a patient, if you do hyperthermia, I will not treat you. They're so against it because, and so in those situations, sometimes I get to talk to the doctor, sometimes they don't want to talk to me. So it's it's a quirk, I think, in human nature. And doctors are human. And so when that happens, I just say, look, your main therapy is your oncology. And there's a very big pressure for a patient to not upset their oncologist. Not every patient tells their oncologist they're doing hyperthermia. Not every patient wants their oncologist to know. I mean, it's a patient specific. Again, we advocate full transparency, recognizing that we're going to get some of those responses. And, it puts a patient in a very awkward position. We're pretty low pressure here. I mean, if you want to come and it fits and everybody's cool, let's do it. But what the reason I don't like that second response is not only is it heavy-handed and intense, but if somebody tells, I remember 10 years into my practice, I would think, well, if I haven't heard of it, how good could it be? 20 years into my practice, I was like, you know what? Probably a lot I haven't heard about. So if somebody said to me, look, I've got an FDA approved therapy here, I would do one of two things. Either I don't have time to look at it, which is fair. It's FDA approved. Okay, great. Then at least it's FDA approved. Your insurance is paying for it. Probably it works. Type thing. Or I would look into it. So those things to me are reasonable responses. But people are people, and so we get a variety of responses from our colleagues, and frankly, we get a variety of responses from patients. Most of them love it. I mean, what's not to love other than the time commitment? Assuming it's covered, right? I mean, but some people don't want to, and there's no pressure to do it. We're here as a resource. We're here to give you an edge. If that edge is going to turn your life upside down, if that edge is too scary to you, if that edge is whatever, then you can't adequately engage in it. It's okay. But if you can, why not?
Yeah, I understand both sides of it. That I think a version of myself 10 years ago would really dig my feet into the sand and say, well, my doctor works for me. I pay my doctor. You're my employee. You don't get to tell me what to do. And then there's another side of me that says, when you have oh goodness, when you have the guy that's in Tiger Woods' ear telling him exactly what to do, you are pairing with a professional because you want the elite of the elite seeing the terrain on your side. So they're not going to let you wander off and take advice from Instagram. So I really do in this world, I think it's so interesting to be able to hold both conversations and multiple truths at the same time. It's just an exercise or a life skill. So I can understand it all. I want, you've mentioned how many centers are there in the US? You said there's
Yeah.
not many.
So there's one other modality that uses microwaves, and there are a few centers, maybe 4 or 5 throughout the
Okay.
United States. So really, when you add them all up, and most of those centers are within academic centers, and they really, so even though the therapies are FDA approved to be used in all solid tumors in combination with chemo or radiation, and you say to yourself, there are probably relatively few people where this does not apply to. Some it doesn't apply to, right? A central lung tumor I can't treat, as an example. But why not? And so what I find, and this is not primary knowledge, but from what patients tell me, they often don't. They often use them at the other centers in pretty narrow circumstances. But again, I'm not at those centers. I don't know that from a primary perspective. And I can understand that as well. I mean, look, you want to be able to be evidence-based. On the other hand, devices are a bit different than drugs, especially devices that have fairly favorable adverse effect profiles, because with medications, the FDA typically will, first of all, they don't tell doctors how to practice. So if you had a particular drug and you wanted to give it off label, you can do that as a doctor. Now, the insurance company may or may not pay for it, mind you, but you can do it. You do anything you think is medically appropriate. With devices, it's a little bit different. The device is going to do what the device does. So, there tends to be a bit more latitude, whereas the FDA will typically want drug A to be investigated in this cancer in this stage, many times because there's a very specific pathway that they're targeting, especially with the newer drugs, right? So you can't just say, well, we're going to give it to every cancer patient with a solid tumor, because there's a whole side effect profile on the other side of it, and it targets a very specific pathway. And if that patient doesn't have that pathway and it's not researched in that way, that's a lot different than applying a device that's going to do the same thing in every tumor. And again, has its own limit. But by the way, I'll reiterate, we have our own limitations. So it's one of those things where you've got to just have a really open conversation with people and just go with the flow and be there as a resource for people that are comfortable and want to embrace it.
Yeah, I understand that. It's a head scratcher to me with the numbers like 44% improvement, 59% improvement, 83% improvement, that it's left out of the modern medical literature as far as training. This Charlie Munger, very famous financial investor,
Warren Buffett's partner.
Yeah. Show me the incentive and I'll show you the outcome.
Right.
So I wonder what it takes, to change this model and get this integrated in more places, that it is a tool in the toolbox. That's all I'm saying. I'm really interested in that conversation and see how it could evolve. Do you have any ideas or any dreams to have this be adopted on a broader level?
Yes, I do. I think probably we couldn't have had a resurgence 20 years ago, because I think we're so internet driven in terms of awareness. The thing that I think patients find refreshing, and I think my colleagues do when I do get to talk to them, is very rarely do they shut things down when I talk to them, my colleagues and patients, because they understand that I've been well trained in Western medicine. I also go with the evidence. I don't overpromise things. And so I think the organic nature of having a genuineness about how, when, and where this should be applied, and whether it should be applied, and the fact that the patient needs to be an advocate because it's so time intensive, actually favors the real organic growth of what we're doing, because we can legitimately put it in the patient's hands because they have me as a backstop, and I'm always going to tell them the pluses and minuses. Okay. So that's where it starts. Where I think it begins to gain steam is as we progress, we're going to, just the same as your podcast, you kind of get a groundswell, and then all of a sudden there's some notoriety around it. So I think that's where it's going to happen. And I say it that way because we're already FDA approved, right? So even though, look, there's a million studies I'd love to do, and there are studies being done, like with immunotherapy. Until we get a critical mass of patients involved, we simply won't have the numbers, regardless of whether we have the funding. So the point is, sure, eventually I'd like there to be more studies where we're like, okay, look, now with this particular therapy, or this class of therapy, we can do that, this, that, or the other thing, which is being researched. So that would be kind of an end game for me. In the meanwhile, it's groundswell from social media, it's groundswell from things like informative podcasts, and people listening to me. Again, they cannot call our center. I would encourage them to call our center, but it's however you're going to incorporate how you want to deal with the engagement of your illness, and we're open for business. We're ready to roll.
Yeah, that's great. Well, I certainly appreciate I appreciate the low pressure energy
Yeah,
behind the message. I appreciate the fact that you're there to offer data and your experience, and I really love the idea that it's you're giving a person a choice. And I think there's a real piece of empowerment there, and there's doesn't feel like there's this fictitious timeline around needing to do this today or tomorrow. This is an option. This is a tool in the toolbox. As you said, we've been approved since the 80s. It's got great data behind it, and so I celebrate the way in which you're doing business and which you're giving the message for it. I think it's really amazing.
well, thank you very much. And I think, what patients will find when they come in is they get the added benefit of another cook. Consider me a sous chef, by the way. But another cook in there it's not gonna overinterpret. It's not gonna do anything other than help them to understand their disease better, so that I can better help them and they could feel more comfortable interacting with their oncologist. So again, that's the added benefit. The main thing that we're doing is we're doing hyperthermia. The
Yeah.
added benefit is we get to have conversations with patients and help guide them in terms of how they approach questions and such.
Yeah. Can I just recap the mechanisms of action? So, from my understanding, it's helping to increase blood flow. So, we're getting more of the medicinal, more of the chemo to the tumor.
Mhm.
The heat is slowing the enzyme repair of the damaged DNA. And then we did increase blood flow. What else was there? What are other mechanisms?
There was the ability to radiosensitize, because radiation needs oxygen to work optimally.
Yes.
And so
Okay.
there's a low oxygen tension at the center of the tumor. So it takes the oxygen and it forms oxygen free radicals, specific toxic chemicals that damage DNA. And it needs oxygen to do that. So we help to radiosensitize. And then also we have the immune reaction.
Yes. Yeah. I love it. Well, it's been such a treat having you on the podcast and asking all these. I feel really empowered having this data, because I get a lot of questions all the time. People are like, Freddie, this isn't working. What do I do? Where do I go? I'm overwhelmed by information, right? So I think it's
Sure.
really good to have these conversations. It's an excellent jumping off point for people to explore. If you had a little magic wand and you could turn everybody who's going through cancer right now, you can wave your magic wand, you can tune in a television station to your channel, Dr. Joseph Pinzone. What would you say to people right now that are going through cancer and oncology?
Yeah, I would say that probably the most important thing you can do is to slow down, use your faculties to help your doctor help you by formulating the right questions. I actually, before I ever came into the hyperthermia world, I wrote a book called Fireballs in My Eucharist, where I go through how to fight cancer smarter, and I help tee up how to ask the right questions. To me, that's the message that I'd like to get across to patients. And the way I came up with the title is I was in my residency and I was getting a history from a patient in the emergency room. And she was telling me about what she had. And she said, oh, and I had fireballs in my Eucharist. And what she meant to say was she had fibroids in her uterus. And that's when I realized patients really need to drill down into what exactly they have so that they can come back up and help the experts in their life, their physicians, help them better. And they do that by not becoming doctors, by formulating the questions that have a good technical backing and a good emotional backing for what is ailing them in their life.
Yeah. Yeah, I think that's a beautiful statement. Ask better questions. We'll get better, higher quality answers. And then the final question, the Beautifully Broken podcast, putting the beautiful pieces back together in whatever format you see fit. What does it mean to you to be beautifully broken?
I think what that means is that we're born flawed. And I think the people who have the most success and peace in life embrace their flaws. And that allows them to lower their defenses and find out what are their strengths. So they leverage their strengths and then they fill in the gaps with others around them who have strengths that are needed in that situation, which is why if you're really good at formulating questions, great. If you're a doctor with cancer, you're going to have better questions in general because you're in the know, although everything cuts both ways. But that's why you bring a family member with you. That's why, if you have a family member who's, I've helped many family members now by being their doctor, by helping them to ask the right questions, right? So beautifully broken means we're all flawed. Lean into it so that you can understand your strength and you can then get others to bolster with their strengths. And now you're really cooking with gas.
Yeah, beautiful. It's been such a treat. Remind people where they can find you and where they can reach out and find the center.
So the best thing to do is to log on to our website at hcioncology.com. And right there, you'll be able to put in a query to us. You'll be able to call our center. Actually, since I don't call our center regularly, let me make sure I get you the correct number to call.
Sure. Oh, wait, I got the contact button up here. I have
there you go.
888-786-0997. That's 888-786-0997. And we've got a location in Santa Monica as well as Irvine.
Correct. And it's HCI Oncology, all one word, HCIONCOLOGY.com.
Perfect. Such a treat. Thank you so much, Joseph.
All right. My pleasure. Thank you for having me.
Big love.